Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
As a National Cancer Institute designated institution, the University of Kansas Cancer Center provides the latest and most innovative treatments for metastatic prostate cancer. This includes immunotherapy for metastatic prostate cancer patients, as well as leading-edge clinical trials and treatments for men with disease that has spread. With me to talk about advancements in metastatic prostate cancer treatment is medical oncologist Dr. Rahul Parikh. I'm Dr. Roy Jensen, director of the University of Kansas Cancer Center. Thanks for joining us for today's episode of Bench to Bedside. So, Dr. Parikh, let's start off and define what metastatic prostate cancer is and talk about why it occurs and how frequently men are diagnosed with metastatic disease.
Sure. So, Dr. Jensen, thank you for having me and providing me with this opportunity to talk about a topic which is pretty dear to my heart, metastatic prostate cancer. We'll talk about what metastatic prostate cancer is defined as or means. And so whenever prostate cancer spreads beyond the prostate to involve other parts of the body, that is classically described or defined as metastatic prostate cancer. Now, very commonly, this spreads to the surrounding lymph nodes in the pelvis, but more often it spreads to bony areas, and that is the most common site of metastasis. A number of times I get asked whether if the prostate cancer is spread to the bones, is this bone cancer? And the answer is no. We still treat this as stage 4 or metastatic prostate cancer. The reason being, whenever we look at these bony areas under the microscope, we see prostate cancer cells in these bony sites, and you would treat them as you would treat someone with prostate cancer. Talking about why this happens, usually this happens due to floating cancer cells. And whenever there are floating cancer cells which spread beyond the prostate, either by the bloodstream or by the lymphatics, they eventually settle down and grow either in lymph nodes or at bony sites, and this leads to metastatic prostate cancer. Most of the patients that we see initially have been diagnosed with localized disease, and roughly this incidence last year was about 190,000 patients in the United States. So this is a very common disease. It is a public health problem, and over a period of months to years, I would say, nearly half of these patients who have been diagnosed with localized prostate cancer eventually develop metastasis either to the lymph node or the bony areas, and in some cases involving organs like the liver and lungs. Along with that, there is a small proportion of patients, I would say about 10 or 15% of patients who actually come in with metastatic disease right at the presentation. So they could present with pain or poor appetite, and when we check PSA levels, which is a blood test, or scans, we note that these patients have widespread disease involving bony areas or lymph nodes. And this group of patients, even though it's small, what's important to note is they tend to have very aggressive disease, and their prognosis usually tends to be poor compared to patients whose disease eventually grows from localized disease over months to years, and then they develop metastatic disease.
So what are some of the most significant advancements we've made in terms of treatment for metastatic prostate cancer?
And to talk about this, I'm actually going to give you some background to the audience about what treatments we have available about 10 years back. So this was when I graduated right out of fellowship. And the only treatments we had available at that time were hormonal treatments in the form of androgen deprivation therapy. And if patients progressed on hormone therapy, then they moved directly to chemotherapy, agents like docetaxel or mitoxantrone. And a lot has changed since. So we have novel hormonal agents which have been developed. We have a vaccine which is commercially available and FDA approved for treating metastatic prostate cancer. We have a radiopharmaceutical agent called radium-223. So clearly over the last 10 years, there's been big developments in the field. What I would say is these developments have clearly helped patients live longer, but also live a better life in terms of their quality of life. Two specific aspects in terms of these advances that I would like to point out is one, for patients who are diagnosed initially with hormone-sensitive disease, they used to be treated with injections which deprive our body of testosterone. And the reason we tended to do that is because prostate cancer is a hormone-dependent cancer early on. As we lower testosterone, testosterone acts as fuel to the cancer cells and causes them to grow and spread elsewhere. And by lowering these testosterone levels using injections or sometimes oral medications, we used to starve the cancer cells, and this used to help us provide control of the cancer for a number of years. More recently, there have been a number of advances to treat this early stage metastatic disease, where we have combined these hormonal therapies either with chemotherapy or with secondary or novel hormonal agents. So examples of these are docetaxel chemotherapy, which was initially looked at combining it with kind of hormonal agents up front as part of a big phase 3 clinical study called Chartered. Subsequently, there was another agent called abiraterone prednisone, which essentially blocks the remaining 10% of testosterone production. And this was looked at in a large phase 3 clinical trial called Latitude. And what happened is, based on results of these studies, patients actually lived almost a year and a half to two longer compared to treatment with just hormonal treatments upfront. Subsequently, over the last couple of years, we have had two big studies, one called Enzamet with an agent called enzalutamide, and a second one called Titan with an agent called apalutamide, both of which now we have used it upfront to treat metastatic disease right when patients are diagnosed. And again, these advances help patients live longer, and they've also significantly improved their quality of life. Now, once patients develop resistance to, actually the disease becomes resistant to these hormonal treatments, they develop a state called castrate-resistant disease. And this is a really aggressive form of prostate cancer. Once patients develop castrate-resistant disease, their survival ranges between 3 to 5 years. And this is the disease, as clinicians, that all of us worry about. So in this specific stage of disease, looking into the biology of the disease is really important. And this is where targeted sequencing, where we look at specific genetic changes within the cancer, really helps us out. So an example to this is nearly about 10 to 15% of patients with castrate-resistant disease will have mutations or alterations or changes in a group of genes called DNA repair genes. Examples of these are BRCA1, BRCA2, ATM, but all in all, there are about 17 of these DNA repair genes which can be altered or modified in patients who have castrate-resistant disease. And we are now able to detect these changes either in previous biopsies of the prostate or lymph node, or more recently using circulating DNA, which is present in the bloodstream. So this allows us to test for these changes. And the way this helps us out is there are specific designer drugs or targeted agents directed to these changes, which work very well for this group of patients, which is about 10 to 15% of patients with metastatic disease. Mm-hmm. So again, lots of advances being made both in terms of the biology of the disease and understanding it, but I would say also in terms of all the treatment options which are currently available for these patients.
So I think, you know, something that's pretty clear that comes out of that is that clinical trials are absolutely essential to figuring out the role of these specific agents. And obviously, as an NCI-designated cancer center, we strive to make sure that our patients have access to clinical trials that are not available elsewhere regionally. Why, if you could expand upon, you know, why you think this is so important to make these trials available to our patients?
So, Dr. Jensen, you're exactly right that as an NCI designated cancer center, we get first dibs on a number of clinical trials, but in general also some of the latest and greatest research being done at kind of the research center. So as an NCI designated cancer center, we collaborate with a number of other centers, and we have the ability and we have opened a number of clinical trials which are available to patients. So overall, what we are trying to achieve with these trials is take the best existing standard of care and improve on that. So we take currently what is available to treat prostate cancer and we make changes or additions to that existing treatment so that patients are able to do better, and that is kind of our end goal. Additionally, what it allows us to do is follow these patients very carefully over a period of time and look at outcomes in a very controlled environment. So I would strongly encourage participating in clinical trials. My firm belief is that it adds to the existing number of treatment options, and you are able to get a novel agent which otherwise may not be available or may not be FDA approved for treating metastatic prostate cancer. I would, in this scenario, specifically like to highlight some of the clinical trials that we have opened here at KU to give specific examples. And the first couple of trials involve immunotherapies. So till date, immunotherapies have not been FDA approved to treat metastatic prostate cancer. And this is where we harness the power of the immune system to fight prostate cancer. And the first example I would like to share here is a study called COSMIC-021. So this is a study where we use a combination of an immunotherapy called atezolizumab, which is a PD-L1 inhibitor, along with an oral targeted agent called cabozantinib. And we use it in patients who have developed castrate-resistant disease after progressing on initial hormonal treatment. The early part of this study was reported a couple of years at a big national meeting at ASCO. And what they noted was that there were really good improvements in response rates, which was about 35%. And in about 80% of patients, this combination could keep the disease under control. So this is an example of a study which we have opened here with agents which otherwise you would not be able to receive outside of a clinical trial. A second example of immune agent that we have here is CAR T cells. So these are genetically modified T cells which are engineered to fight a specific protein present on prostate cancer cells. And we have a clinical study using CAR T cells for prostate cancer open here at KU currently. The nice part about that specific study is that it allows patients with any number of prior lines of treatments to be on that study as long as they meet certain criteria. And then the third study, which is very dear to me and I would like to highlight, is a study called COMRADE. So this was a study which kind of we opened as part of the early phase clinical trials group through the NCI. It is funded through the NCI. And a number of patients with prostate cancer develop painful bony metastasis. So for these patients, one of the treatment options is an agent called radium-223. The way radium works is it emits alpha radiation, which causes DNA breaks. And radium currently has been FDA approved to treat these patients with painful bony metastatic disease. On this specific study, what we are trying to achieve is we take radium-223 and we combine it with an agent called olaparib, which is a PARP inhibitor. So olaparib itself is an oral agent which blocks DNA repair. And the whole thought process is that combining these two agents would help the radium-223 work better. So this is, again, a clinical study which we have available. We have completed the initial early phase portion of the study, and we have moved on to phase 2 portion of the study with these agents. And this is just an example of how NCI supports us through grants and through some of these very novel clinical studies to provide excellent treatment options for our patients.
Well, those are great studies. And if you're just joining us, we're here with medical oncologist Dr. Rahul Parikh to talk about advancements in metastatic prostate cancer treatments at the University of Kansas Cancer Center. And Cameron Poindexter is here taking your question. I think we already have a question, but if you would like, please post them in the comments below. And remember to share this link with people who may benefit from our discussion. Use the hashtag bench to bedside. So Cameron, what is our first question?
Yes, we actually have two questions. And the first question is, how important is screening for prostate cancer in terms of treatment options? When should people start getting screenings?
I'm sorry, I could not hear the question.
So the question was about screening and selection of treatment, I believe?
Correct.
So how important is prostate cancer screening in terms of selection of treatment? And I assume that relates to stage of diagnosis and whether or not it's an early stage versus a late stage cancer.
Right. So for some of these clinical trials, we require patients to have metastatic or stage 4 disease to participate on these trials. Again, we have separate trials which would involve patients with early stage disease. The trials that I highlighted, patients usually tend to have castrate-resistant disease where they have become resistant to an initial form of hormonal treatment. And again, for that group of patients, they have a limited number of years to live and limited treatment options, and that's where some of these trials become really important.
Mm-hmm. And our second question, Cameron?
The second question is, what is an early phase clinical trial?
That's a great question. So an early phase clinical trial is a trial where we are looking at essentially side effect profile of a particular agent. And for these early phase trials, sometimes classified as phase 1 or phase 2 trials, we recruit patients in cohorts of 3 or 4 to look for toxicity. Now, more recently, that early phase clinical trials have evolved where we start looking at efficacy or how well these agents work in these early phase clinical trials. So usually the advantage of an early phase clinical trial is that there may not be any placebo or controlled arm. So all the individuals who enroll on those studies are pretty much guaranteed to receive that study agent. The downside of kind of participating in an early phase clinical trial is one, sometimes the side effects may be unpredictable, and so we actually tend to see these patients very often in clinic and follow them very carefully. And secondly, we may not have any background information or any prior knowledge of how well these agents work for patients with that particular condition. Having said that, a number of agents which have now been FDA approved have made their way up from early phase clinical trials where they worked really well, they had few side effects, and then eventually to phase 2 trials and phase 3 trials, which are truly kind of the landmark studies, and then get approved.
So, one of the things that has kind of risen to the top of our clinical program is the importance of getting second opinions after receiving a cancer diagnosis. Could you tell us about why you think that's so important and why that's particularly true in the case of a patient who's received a diagnosis of metastatic prostate cancer?
So I would say getting second opinion is crucial for metastatic prostate cancer. And in general, I would say prostate cancer, especially metastatic prostate cancer, is a very complex disease. One person with metastatic prostate cancer can have a completely different outcome compared to the person next to him with metastatic prostate cancer. And this is true for cancer in general. The treatment paradigms have evolved and have become really complex even in the last few years or so. And so it's always good to have a second set of eyes, review your pathology, review your imaging studies, review the laboratory findings, and then talk about potential of clinical trials or treatment options for you. And I think that's where second opinion comes in. We have a really good team of urologists, radiation oncologists, medical oncologists like myself, pathologists, and radiologists who actually get together as part of a disease working group. For a number of our patients with complex prostate cancer, we meet and talk about the findings, and then we try to come up with the best possible recommendation for you for your prostate cancer. So to me, getting that second opinion from this entire team of experts and recruiting them is really beneficial. I would, in many sense, look at us as your allies in this fight against cancer. And a number of times what we tell patients is, hey, you've seen this person in the community and this is exactly what I would do. And this provides actually some sense of reassurance to the patients that this is what we need. In a number of other patients, we are able to provide diagnostic tests or clinical trials which would otherwise not be available closer to home. And in that sense, I think it's really important to get a second opinion.
Mm-hmm. So Cameron, it sounds like we have another question.
Yes. The question is, given concerns around accuracy of PSA results in determining the presence of cancer, is there a different test you would recommend? Liquid biopsy tests seem to be emerging, but they're interested in hearing your thoughts about it.
Test other than PSA?
So again, that's a great question. Traditionally, when patients initially present with prostate cancer, PSA is a blood biomarker test, which is extremely sensitive and specific for prostate cancer. And it works really well at kind of telling us what's going on with the patients, both in terms of initial diagnosis, but subsequently in terms of response to treatments as well. Now, as patients progress through hormonal treatments and become resistant and develop castrate-resistant disease, there are additional tests in the form of imaging studies, in the form of, as mentioned earlier, certain blood tests looking at changes in certain molecular markers that we can do. And about a year back, FDA approved one of these blood tests to look for cell-free DNA, looking at DNA repair changes. So what I would say is that for patients who have developed castrate-resistant disease and who are eventually running out of some of these treatment options which are otherwise FDA approved, checking that test, looking for some of these DNA repair changes, but also a group of genes called mismatch repair changes, which occurs in about 1 to 3% of patients with metastatic prostate cancer, becomes really important. And that is a scenario where I really want to test these patients who have developed castrate-resistant disease to look for these changes to see if they are eligible either to receive oral targeted agents like PARP inhibitors, or certain types of immunotherapies which have been approved. Pembrolizumab, for example, has been approved for patients who have mismatch repair changes. And at this point, we have tried to integrate that testing into kind of our care models, where if patients see us with castrate-resistant disease, we are automatically trying to order these tests and get that information because the turnaround time for that test is anywhere between 4 to 6 weeks.
I see. Another question, Cameron?
Yes. If the radiation killed the cancer from the bone, will you be able to take the prostate out?
So again, that is an excellent question. Currently, for someone who has metastatic disease, we do not have enough evidence to understand whether removing their primary site of disease, which is the prostate, whether removing it or radiating it or any form of local therapy would be helpful. In fact, we have a large phase 3 clinical study which is sponsored through SWOG, which we are participating in, trying to answer this specific question. So this specific trial, what we offer is patients with initially diagnosed with metastatic disease. They undergo hormonal treatments with additional treatments, and we then randomize these patients either to observation, or they are randomized to radiation, or they are randomized to surgery. And this study hopefully will read out over the next few years, and I kind of have an objective response to that question. But I think that's a great question to ask. In a select group of patients, I would say, who have really symptomatic disease in the prostate, I think it makes sense to help radiate the prostate or kind of think about local treatments to the prostate. And the goal there is to help with the symptoms of the disease.
So, Dr. Parikh, could you tell us why you think it's important for patients who are diagnosed with prostate cancer to be seen at a minimum for a second opinion at an NCI-designated cancer center such as KU Cancer Center?
Right. So, Dr. Jensen, as you know, NCI, the National Cancer Institute, has provided us, and it kind of has funding to do excellent research at specific institutes. And there are about 70 such institutes in the United States. We are the only NCI-designated cancer center in the state of Kansas. And what essentially this tells me is that there is a critical mass or a critical body of researchers, of clinicians like myself, and of support staff who all get together to take care of patients with metastatic prostate cancer. And this really helps outcomes, but it also kind of improves on the care delivery system. And from a patient perspective, what I would say is care at an NCI-designated cancer center through studies previously has shown better outcomes for both surgical kind of outcomes, but also outcomes for cancer per se, in terms of how long patients live and how well they do. Secondly, at an NCI-designated cancer center, you'd be seen by a team of experts. So it's not an individual, but it's an entire team working together to provide this care and provide the best possible care for you. And then finally, at an NCI-designated cancer center, we have expertise in certain molecular testing, but also our approach to clinical studies, which you would be offered, which you may not have kind of available closer to home or out in the community. So all in all, what I would say is it is important to get a second opinion at an NCI-designated cancer center.
And I could provide personal testimony in that regard as well. My father was diagnosed with prostate cancer and was treated for a couple of years in the community. And I talked him into seeing a medical oncologist at an NCI-designated cancer center, and that resulted in a complete change in the therapeutic approach. And we took basically an angry 65-year-old postmenopausal man and turned him into someone who was happy, healthy, and was enjoying life for another 20 years. So it makes a huge difference.
It does. And I think clearly we have seen these instances, but also what I would say is we are allies in this fight. And a lot of times we work with kind of your local oncologist so that if we are able to provide this best set of care closer to home, that's kind of also our goal. But I think, Dr. Jensen, you're exactly right.
Yeah. Cameron, it seems like we have another question.
We sure do. The question is, what are the prospects for making PSMA PET scans available at the University of Kansas Cancer Center? Any timeline? Do you think it would be useful for patients with no metastatic disease or only for early screening and staging?
Again, I think this is a great question. So recently, PSMA PET scans have been FDA approved to evaluate patients with metastatic disease. This is an extremely sensitive scan to detect early disease. They're currently available just at a couple of sites in the United States, and we are working towards or developing that technology here. We have formed a group to look into this. I don't know of the exact time frames or timelines that PSMA PET scans would be available here, but we have clearly looked into this and we are working on getting these available to our patients.
Yeah, I've personally been involved in trying to arrange for this, and as Dr. Parikh said, it's only available in 2 sites right now, and but we are working with the company that once they broaden the access to that agent, we will be able to quickly get up to speed and offer that test here. So, Dr. Parikh, what would you say, or what would you most like our listeners to take away with them from today's discussion?
So the 2 specific things I would like to take away is please get a second opinion regarding care for metastatic prostate cancer for yourself or for your loved ones. And the second message which I would like to provide is I would strongly encourage you to look into clinical trials or clinical studies. And again, these help expand the treatment options which are already available. So I would strongly encourage you to look into trials and think about it as an additional treatment option.
So I'm going to follow up on one thing you said there. Do we have telehealth second opinions available for our prostate cancer patients?
Absolutely, yes. So this is a program that we have tried to develop for our patients with both early stage disease and metastatic prostate cancer. And broadly speaking, we have had a really rough 2020 with COVID-19 crisis and what's been going around. And I think the silver lining, if I could say that, to the COVID-19 crisis is this rapid growth and expansion of telehealth services. So this involves phone calls, this involves video conferencing with our patients. And the advantages it provides is, one, it allows patients to get a second opinion from a distance, and we are able to review charts, review pathology, kind of review radiographic tests, and tell the patients this is what's going on. But also it allows us to stay safe at home. And again, these telemedicine or telehealth visits for prostate cancer, we have designed it in a way that you see a medical oncologist along with a radiation oncologist, along with a urologist, depending on your needs, so that you are seen by an entire team of physicians with staggered appointments on the same day. And this allows us to review your care very carefully and then provide the best recommendations for your care.
Do we have any other questions before we close out, Cameron?
Yes. The last question is, in your own opinion, when is the germline testing appropriate?
I assume they're talking about germline BRCA1 and 2. Yeah.
And again, this is a really good question. This has come across quite a few times. In my opinion, I offer germline testing to patients who have 2 or more family members with a diagnosis of either prostate cancer, ovarian cancer, breast cancer, or pancreatic cancer in the family. A number of times when we do testing on tumor tissue or kind of on the blood, we are provided with results of genetic changes. And there are certain genetic changes which are based on the frequency or the type of change involved. We can accurately say that this may be a germline change or a germline mutation. So again, for these patients, based on kind of the testing that they had on the tumor, we can sometimes say, I think you require germline testing, or if there is a pretty strong family history of having certain types of cancers associated with these genetic changes, we offer genetic testing to patients.
So I think in addition to that, I think there are some folks who advocate genetic testing in any case of metastatic prostate cancer. So what do you think about that?
I think that is overall an excellent idea. I think at some point we would get there. My concern with that is that we need to have this critical mass of genetic counselors and team members who are able to review these results and talk about these results with patients. And so I believe we are getting there, and I think that's an important step towards kind of screening all patients with metastatic disease. I feel we are not there yet.
Okay. Well, thank you, Dr. Parikh. That's it for today. To learn more, please visit kucancercenter.org/prostate. Join us next time for Bench to Bedside.